Hello, everyone. Welcome to our webinar, From Design to Delivery, Co-Creating Multiple Patient Scenarios for Nursing Curricula. We're delighted to have you today. I'm Dawn Marie Dunbar from Oxford Medical Simulation, and I'll be your host today. A few housekeeping things before we get started. The webinar will be approximately 15 minutes with a 5-minute Q&A at the end. If you have any questions, please put them in the chat and we'll do our best to answer them at the end during the Q&A portion of the webinar. We will have this recording available on our website following the presentation today, and we'll also send it out via email to all the participants. It is my pleasure to introduce to you our speakers today. We have Dr. Cynthia Bradley from the University of Minnesota and Dr. Ann Loomis from Purdue University. So ladies, take it away.
Thank you.
Thank you, Dawn. So we are super excited to be here today to talk about this project. We actually love to talk about this, just with what we've done with VR and the potential that we see for immersive VR in the future of simulation education. You're seeing a slide here of the rest of our team. So this project, we called this the Big 10 Practice-Ready Nurse Initiative team. You're seeing Michelle Abersold from Michigan, and then Ann Loomis, who is here with me today, and then Linda DeClementi from Michigan, and Carol Flatten from the University of Minnesota. So to begin, we always like to just set the stage to make sure we have all of our terminology correct. So we're looking here at a slide that just talks about extended realities. So extended realities is really the big umbrella term that we're working under, or it's often referred to as XR. So this term encompasses all of the realities that are technology mediated. XR can use a variety of hardware and software, all of this to create these sensory interfaces and applications that form this digital infrastructure for learning. So we see 3 different types here. This is what we most commonly see now. So augmented reality, unlike the fully digital worlds, AR overlays digital content onto our actual physical environment. This is very commonly seen today through phone or tablet-based applications. And this just adds a layer of information or imagery to the room that you're in. This is common with, you're shopping online, see this in your room or see this on you. So we're very familiar with AR. Mixed reality is just a step further than AR, where it blends the real world with digitally created content in a way so that both exist together and can actually interact. So this is more of a hybrid space, but it allows for more complex engagement between the physical and the virtual. And then on the far right, you see virtual reality, and that's what we're talking about here today, just that full immersion. This is software generated. It's an artificially digital environment, and it completely replaces the user's physical surroundings with a digital one. And so when we look at the levels of immersion, you can see as we move from left to right, screen-based VR, that is really not the focus of our project or what we're addressing today. Although many of the immersive VR platforms like OMS do offer the screen-based version where users can use the software on a desktop or a computer. And then moving farther to the right, the level of immersion goes up with AR, then with MR, mixed realities, and then finally with immersive virtual reality, which is the most immersive environment that we can interact with. So when we talk about immersion, I really want to differentiate from desktop simulation or desk-based VR. So many platforms offer this, but I want us to be very cognitive of the science of immersion. I could literally talk for the rest of this hour about the science of immersion because it is very, very powerful. With immersion, we are looking at this is sheerly related to the ability of the technology to generate these realistic experiences. And so if you just Google it and you look at a little bit about the science of immersion, you can see how everything works together to just take over all of your senses, from what you hear, what you see, what you can feel through through the haptics, but all of the technology that drives each of those components is what builds immersion. So that is very objective. That is what is created for you. Presence is what we feel. So in a lot of research, we measure the sense of presence. How present did you feel in this virtual environment? How present did you feel caring for this patient or interacting with other team members, maybe in that virtual environment? So those two go hand in hand. We create the immersion to increase that sense of presence. That's what we're looking for with immersive VR. We want to create this presence as if I feel as if I am actually there. That's what we're looking for. And just one last little note on immersion. If you just Google a little bit of the research that is being done using immersive VR, there is incredible stuff happening with rehab for post-stroke patients. Looking at, the mirror neurons, how that works in our brain, where they're actually putting someone who has had a stroke in a VR headset, and they're moving their not affected arm, so their good limb, say their arm, and it's actually impacted their affected side because of what it's doing. It's building that neuroplasticity in the brain. So just think about that for a minute. If that is possible, what are we doing with our learners when we immerse them into these headsets? Just think about how powerful that learning is. So here are just a few pictures of we're creating this digital environment, this other world, but inside this world, we're doing this. We are nurses or whatever healthcare team members we are. We are doing these things. We are caring for our patients, and we want our students to feel like they are really there. They are doing this, and it is extremely realistic for them. So the purpose of this project that we're talking about today was to develop and test the impact of 5 multiple patient experiences on our senior students' ability to provide care. So this funding call that came out was the American Nurses Foundation. They wanted to look at how can we improve practice readiness of nurses. So we thought, well, let's look at senior nursing students. And when we thought about it, we wanted to see, like, what are the things that are really inhibiting practice readiness, or what are the things that are deterring from that? So we thought about how with nursing students, they never really get to take care of more than 1 patient, maybe 2 patients, but never a full caseload of patients, which is, realistic, real world nursing care. So the question being, when they enter nursing practice, if they've never really experienced the caseload of what a nurse would experience in a regular acute care medical surgical setting, how practice ready are they if they've never experienced that? So that was our goal. So this was just one piece of the study of looking at how can we improve practice readiness. So we thought, let's create these multi-patient scenarios with these students. So that's what we did with Oxford Medical. And then we implemented these. We started with three Big 10 schools. So University of Minnesota, where I am from, and then Purdue University, where Dr. Loomis is at, and then University of Michigan, where 2 of our other co-investigators are located. We developed for 1 year, we implemented this for 1 year at our sites, and then we replicated this at 3 additional Big 10 schools, thus the Big 10 project. So talking a little bit about the method of how we developed this, I'm going to turn this over to my colleague and great friend, Dr. Loomis.
Thank you. Yes, we were so excited when we first delved into this project and thinking, what is it we're going to do that's outstanding and different and unique? And our whole team came back to a concern of our nursing students is getting out into active practice and having never cared for multiple patients. So this was a big to-do for us and a push to see what we could do to try to advance this. So we did develop the 5 multi-patient VR scenarios, and we were excited to work with Oxford Medical on this journey. And how were we going to create the scenarios to really reflect the stressors and the concerns of caring for multiple patients? And with OMS, we were able to do that. So we'll get more into that in just a second. But we also revised the Creighton Competency Evaluation Instrument and had that honed into 28 items for clinical and IVR. So then we had the CCEI VR, which aligns with the computer-generated data analytics. And that opened a whole nother beautiful information source, we will say, and we'll tap into that in just a second as well. So with these 5 multi-patient immersive scenarios, our focus was not on the skills. What we wanted to look at was cognitive skill development, not the physical skills that are required to take care of complex caseload of patients. It's very challenging of how you're going to manage these patients. Who do you see first? What do you do? How do you prioritize, delegate? So that is where our focus lies. We want to look at clinical judgment. How are these students going to assess the patients under their care? Would they recognize cues that the patient was deteriorating or in distress or in need? How did they notice and observe these different signs? And then how did we analyze this? And were they capable of identifying trends that would impact their patients? So a heavy focus on the clinical decision making. And with that wrapped up, prioritization and delegation. Again, something that most students do not get to do. They're often delegated to, but then they're unsure how to delegate once they're in active practice. And the same thing with prioritizing. When they've only taken care of 1, maybe 2 patients, that is challenging to learn who comes first and why, and was this the correct decision? So the debriefings became a vital part of this as well. These were the 5 scenarios that we developed with OMS. So OMS did have some patient platforms already developed. And so what we did is we built off of those and we made them specific to our needs, what we felt were challenges for senior students. And again, when we say challenges, what are they going to face in active practice? And that's what we went after. When they're in training and they're working with a preceptor, clinical instructor, or even in our simulations, it's hard to have them care for multiple patients. And it's challenging too to put in distractors and added people that they can delegate to. It's just time intensive. But what we could do was incorporate these features into the VR scenarios. So first up, scenario 1, they cared for 1 patient. And what we found was this also gave them time to acclimate to the hardware. Let's just get used to having a headset on. What does that look like, feel like? It is different from taking care of a live active patient. It is a virtual reality patient. And so a lot of that went into scenario 1. It was a patient in respiratory distress. She had a reaction, they developed a rash, and students had to act quickly, think about what they were going to do and did they need help, etc. Scenario 2, we looked at clinical competency and prioritization. So they had 2 patients. Who did they choose to see first and why? Then when they rolled into scenario 3, we picked up the clinical competency, prioritization, and now task switching. And so when one patient became distressed, what did they do with that patient? When they had another patient they're in giving meds to, were they supposed to just leave them? Did they know they had resources they could call upon? What and how would they respond in this situation? Then by scenario 4, we added in the delegation component. So they had to discharge a patient, but they were being pressured to do so from the charge nurse. They also at the same time had an unstable patient they needed to address, medications that were due. And oh yeah, we had the med student that popped in that needed directions for how to open a room that needed a code. And so they all laughed after the fact in the debriefing, like, oh my gosh, what was all this about? And it's like, welcome to the real world. Everybody pops in and out and needs you at inopportune times. And so a lot of challenges built into it. And then by the time we get into scenario 5, it's a culmination of all these different tasks that they have completed up to this point. So they are taking care of for clarification, the same 5 patients. So it's like the day in the life of a new graduate nurse. Patient 1 is seen again in scenario 2. Scenario 2 patient is seen in scenario 3, etc., until you're up to the care of those 5 patients. Again, a lot of moving parts, lots going on, and then that is where the whole debriefing came in as a priority to help them walk and talk through the decision-making components here. So how we set this up in our programs, we did allow for 2 hours for for the VR sessions, and that was ×5 because we had the 5 scenarios. And this was for seniors only, is how we rolled this out. Students completed the 5 multi-patient scenarios using the Quest 2. And again, this was on their own time. They put the headsets on. We had our 2-hour block, but they were on their own per se, working as an individual. And then they participated in a debriefing in the small groups after completing the scenario. So again, you blocked out 2 hours of time per scenario, and that was 5 scenarios that were completed. So then looking at how to do this, in the beginning, it got far easier after we moved along, like anything. But planning in advance of how you're going to block off your calendars to make sure this is going to work, pending the number of students that you have. And then do you have the classroom or lab space? Where do you want to put these students? Are you going to have them come in groups of 6 to 8, like a clinical group? Or are you going to have bigger groups? How do you want to accommodate them? And recognizing that need of space so you can reserve those rooms far in advance. And then also working in a 2-hour window that you would need that space and time. So working backwards, yeah, be realistic is a fact. Can you accommodate this within your schedule? And what does that look like? And making sure you can fit these in. All 3 of our universities have large volumes of students, typically 175 in a class. So to accommodate that many students, in addition to their regular classes or in addition to their simulation experiences, where does this fall? How do we incorporate the VR component? Then preparing the students was crucial. OMS did a great job of having introduction videos that the students were required to watch prior to their first encounter. It talks about orientation to the headset and to the software. Then on our end, making sure the headsets are fully charged, that the software updates are ready to roll and they don't come on right as a student's trying to activate one of the scenarios. Did we get the downloads ready to roll? Do we have enough of a power source? We do not need drops in connectivity because that oftentimes forces them to start the scenario over. So again, somebody needs to be present with these students during their session to troubleshoot with the headset. Sometimes they would go off or we'd have a battery issue, whatever it is. So somebody needs to be there to help them walk through if they lose connectivity or have any issues in navigating it. And then last but not least, cleaning and charging between. We have our students running at a fine art. They now know you go back to the start charging cabinets, pull out whichever one you want. They're all numbered. When they have finished running the scenario, they go back. We have the wipes to clean all around the headset that touches their face. And then we have lens wipes that are separate. Students do all the cleaning, put them back in the chargers, put them back in the case. So again, time-wise, made it much more efficient for sure. So like any good sim, even though it is a VR, healthcare standards of best practice apply. We followed these diligently. Everything was set up as though you were scheduled for a regular simulation, from how we designed them, what we followed from the pre-brief to the actual simulation design itself, all the way down to the debriefing, ending with how we're going to evaluate. So again, it does meet the healthcare standards of best practice to make sure you're running the best VR standards that you can. All right, so I'm going to hand off back to Dr. Bradley.
Yeah, so then like any good project, we wanted to look at our outcomes. How do we know that students are doing well in VR? How do we know that this is making an impact? Also, because we integrated this into our senior nursing courses, we had course objectives to achieve and we needed to measure outcomes from a course perspective as well. So we collected data in several different ways. We looked at knowledge as one outcome. We wanted to hear some student qualitative feedback. What did they think of the experience? And then, as Anne said, we revised the Creighton competency evaluation. We used that tool in VR and also in clinical. And so we did clinical evaluations at the midterm and at the end of the semester across all of our sites. And then we also used the Creighton, and we had to align it with each of the 5 scenarios, which took a fair amount of work. But it was really interesting to see what that showed us. So Our results are that we successfully developed and integrated the 5 scenarios at a total of 6 sites with over 1,000 students. And as Anne described, we did the 5 sessions across 1 semester as part of a senior course. And just to be very clear, the first session, students took care of that 1 patient. They came back for the next session, took care of 2 patients. And so they went up in order, taking care of 5 patients. We did this over 1 semester of a senior course just because of the tight timeline that we had, and we needed to be able to collect our data in a short amount of time. I will say now that we are beyond that project, at the University of Minnesota, we're kind of trying this a little bit differently, where we're starting with our juniors. And so we're doing the first patient and then the 2-patient scenario in the junior year. And then when students hit the senior year, they'll take care of the 3 patients, the 4 patients, and the 5 patients. I was a little bit on the fence of how this would work, but actually these are med-surg concepts. So a lot of these things, they get these their junior year. And some of it has actually coincided with what the didactic content that they're getting in their junior year. So they're doing really well on those first 2, the 1 and 2 patient scenarios. So the feedback that we received, and I do want to back up just for 1 minute and say, I think I said at the beginning, we started really envisioning this in 2021. And so our funding started in 2022. And so I know that has not been that long, but in the world of VR, it actually is a long time because that technology has changed so rapidly. So when we first looked at this, to our knowledge, there were no multi-patient scenarios in immersive VR. And I think I can say with 99.9% confidence that is true, unless somebody was doing some version of their own platform that was hidden and nobody knew of it. So to our knowledge, this was the first out there. And so it took some time to develop all of that, but this was new. Now you can, I was just at IMSH and there's lots of vendors offering multi-patient, multiplayer. At the time though, this was brand new. And so this took some time for us to intentionally and thoughtfully design this, with our team as the nursing education experts, the simulation experts, and then with our OMS team who were the VR people. We didn't know VR. We learned so much though through that process of collaborating together to develop these scenarios with our students. And then we were able to take feedback from our students, from our instructors, take it back to OMS as we continue to develop and refine. So these are the main things that our students said. Number 1, top of the list, was how they appreciated the opportunity to learn how to prioritize, but then also how to reprioritize. Because as we know, as nurses, students learn this, that what you start off with, what you think is going to happen with your patients, probably never actually plays out that way because somebody has a different need or there's something else that gets thrown into the mix that you don't anticipate. So we're always having to reshuffle that deck cognitively. So, overwhelmingly, that was one of the key takeaways, was learning how to prioritize nursing care. And isn't that something that we all need to become practice-ready nurses? Establishing those priority patients, the priority interventions, that was another thing. We started most of our debriefings with, who did you see first and tell me why? And so just talking them through that, whether they chose that patient or not, they're hearing their students, their peers talk about why they prioritized that patient. The next thing that we heard so much about was when to call a provider. And then second to that is, what data do you need before calling? And we did hear some really interesting stories from students. One student told me that he didn't really know what to do in the scenario, but he could hear a phone ringing from his peers on their headsets who had, their volume turned up pretty loud. And he said, I just thought I should make a phone call. And so he did. and then he told us how, he didn't, he was told, go back and get some more assessment data and call me back. And, as we know, as simulation experts, when you make those mistakes in simulation, you're very likely to not make that mistake again, either in simulation or in practice. So we heard a lot of feedback around just calling the provider, using SBAR communication. That was another big one. Looking at standing orders. This was something that students were really not familiar with. So having to look through a protocol that maybe is different than what they were used to seeing, or they just weren't familiar with that at all. And then time management, how do you juggle multiple patients? How do you, what do you delegate to a nursing assistant? How do you learn what to do? And how does that really help you managing your time? Looking at the critical assessment data and then following up with those interventions, following up with those assessments after intervening for something critical. That was another thing that students talked about learning, but also appreciated being able to debrief those things and really talk through those in the debriefings. Nursing is unpredictable. That was a big one, right? And I love that they named that as a takeaway, because it is. You open a door, you kind of think you know what to expect with the patient, but it's really never how you expect it's going to be. And then staying focused under pressure. I had several students tell me that they were stressed knowing that this patient was depending on them. We're in an immersive environment. We put ourselves in these virtual environments. It wasn't a real patient, but they felt like it was so real. They said their palms were sweaty, or they knew this patient and that family member was depending on them. That's what we wanted to create. So when we heard those kinds of statements, we felt like this was a successful project. I don't care what the other outcomes look like. This is what we wanted to create for our students. And then on the right side of this slide, you see that these are just some basic med-surg things that came up. We wanted to focus on multiple patient care, balancing that caseload of patients. But to do that, we actually needed patients with problems who represented med-surg nursing care. Insulin, glucose, those seemed to be really difficult concepts and difficult things to act through. And we don't know if it's because maybe they hadn't reviewed those since their junior year and these were seniors, towards the end of the program. But we had a lot of students comment that they actually understood the role of insulin and, why this is so important, and just, all of the meds that go into diabetic care and the things that we do. A lot of the actions of medications, specifically with chest pain protocol, troponin. A lot of students didn't really know what that is. So these are just a few of the big ones that students reported really learning from or learning through these multiple patient scenarios that they took away from that. Okay, so one of the great things about VR are the data analytics. And so this was something that I was really unprepared for, just because I knew that there was data that was generated, but when I actually saw this playing out, I was really surprised, but also very excited. I think in a world of competency-based education, competency-based assessments, I think that VR is opening a whole new world for us as far as how do we actually see what students are doing? How do we see them enact the decisions that they're making? How do we look at time on task, the order of actions? But to have a dashboard that shows the time-stamped actions that they did helped us immensely, because we were able to really drill down into different aspects of clinical competence and be able to measure that for each of these scenarios. So if you're familiar with OMS, this probably looks familiar to you. If you are not, this is one of the views that students will see when they finish a scenario. So they go in, they do the scenario. When they end the scenario, they go through a little debriefing. And then they see their feedback. What went well? What are the things you need to improve on? So this is, the green check marks means good. These are the things that you did well. If you are mapping any of your scenarios to the different competency frameworks, you'll see them appear on the screen. You'll also see the time stamp. So students can really look at that as well. Things that didn't go so well or things that needed improvement will show up here. And then they have a little bit of an explanation. They can click on show rationale. It'll show them a little bit more if they want to learn more about that. So there are many, many discussion points. I do want to say one piece about the feedback and the data analytics. One of the things that was unknown to us when we started this was that we were all very, very familiar with debriefing. Actually, Anne and I have done several research studies together where we looked specifically at debriefing following traditional simulation. So when we moved into VR, we thought, well, what will this look like? Because we were used to the traditional simulation where we could see every student group as they went through. And we thought, okay, so with VR, each student is doing this independently. We intentionally chose OMS because we didn't want to have to be a facilitator in that virtual environment. We are both in very large Big 10 nursing programs, and we don't have the resources to do that. And we wanted students to be independent. That was extremely intentional. So we wondered, we won't have time to go look at their feedback. So how do we know that when we're in debriefing, they're really telling us what actually happened? How do we know how to debrief this? And what we found is that students were super, super eager to tell on themselves. And they were very quick to disclose what happened in that virtual space. So we've talked about this a lot. And, you know, I've looked into some literature since then to see, like, what is the explanation of this? Because when you talk about psychological safety, we talk about psych safety in the context of traditional sim all of the time, that we want to cultivate that. This is a safe place. You can make your mistakes here. What I think is that VR is the ultimate environment for psych safety. You are in this headset alone. Nobody is watching you. You can make a mistake, but you see how that plays out. And then, you know, maybe it's not an out and out mistake. Maybe it's just, oh, maybe I shouldn't have done that next. I should have done something else. So you do have some time where things kind of correct or shift because it's all branching. It's all AI driven. So it's all based on the decisions that you make. Students know that as they interact with this. So if they do something that's out of order, or maybe they shouldn't have, you know, or maybe it was just a full on mistake, they were so eager to talk about it because they owned that. It was just them. Nobody was watching them. There was no shame. There was no judgment. And so we found that students talked about their mistakes much more willingly in immersive VR debriefing than they do in a traditional simulation where everybody watched that mistake. So I do think that this opens up just this new area of research and exploration of just this element of psych safety. So I just wanted to really touch on that because I do think it is an important thing to think about as we move forward and continue to build the science of immersive VR simulation. So I think some key takeaways here, just that the VR simulation, it does leverage technology to the fullest, right? We are using all of our resources here to build these virtual environments for our students to interact, to act as a nurse. You know, in our programs, we can't offer multi-patient scenarios with traditional simulation. It would just take so many resources to be able to offer that in so many days, and we can't do that. With offering this through immersive VR, we can ensure that every student can take care of a caseload of patients. If a student is struggling to do that, they can repeat it and they can have that same experience, and it's all responsive to how they act in that scenario. So that gives them the chance for deliberate practice where they can improve each time that they do it. And so I do think that immersive VR brings another tool to us as simulation educators. And I also think it's a much more accessible offering of simulation, and it is much more equitable. Think about, or maybe this is your situation, a smaller school. Maybe you're in an area where you don't maybe have the real high acuity clinical sites, and maybe you don't have access to these high-tech, state-of-the-art sim centers. Well, guess what? It can come to you in the form of a headset. So you have the hardware, you have the software, you can recreate these, you know, totally replicate these patient situations with your students in the absence of a sim center or your high acuity clinical sites. We have great clinical sites where I am situated. I think Anne does as well, as does the University of Michigan. But offering these scenarios really provided students with standardization and consistency. We all know how this goes, right? You take your students to clinical, you are just at the mercy of whatever the patient's census is that day. You are also obligated to uphold the hospital's policies, you know, for safety initiatives. Maybe students are observing more than they're actually hands-on doing things, and maybe more so, they're not making decisions in that clinical care, and they really are just shadowing and observing. So in a time when clinical learning is highly, highly variable, this is one way that we have found to produce or to provide students with standardized, consistent learning experiences. So I think, we've talked about here the real world complexities, the challenges that we can offer. We're not going to go into this much here in this webinar, but I just want you to realize that with the data and analytics that are generated through OMS, through VR software, there's so much more potential for very specific measurement that doesn't involve a rater. So we're removing bias, we're removing that subjectivity, because we're looking at exactly what the data is that's generated through VR. Anne, do you want to jump in and add to this? I know you've had so much feedback from interacting with your students and your sorry, my tongue is not working, and your instructors. So do you want to jump in and add anything there?
I think one of the neatest things we experienced were students sharing that this was the first time they truly were on their own. That, as we were saying earlier, there was nobody looking over their shoulder. There wasn't a peer to turn to and bounce things off of, no preceptors. And that created a lot of angst. It also created freedom. And so they felt, as seniors heading out into the real world, they needed that. They needed to be able to stand on their own 2 feet and have to think through a process with the pressure on. They also commented frequently about the timer that was in the patient's computer, counting down how many minutes left before this session ended. And they thought, if I'm taking care of real people on a 12-hour shift, how would I manage this many with such serious problems? What am I going to do? And they said it created that real angst that Dr. Bradley was referring to, the palm sweating, the heartbeat increase, blah, blah, blah. And they said, but they loved that part of it. And to an earlier point too, that Dr. Bradley made about they were more free in sharing how they felt their experience went. Again, because nobody actually observed what they did, as far as peers, we could go in and see by the data what they did. That was liberating. It allowed them to really go for what they thought they ought to do. Whether it was wrong or right, they had to make a decision and move forward for that patient. And they relished that. And when that debriefing hit, that whole room would be talking. It's like, how many of you, chose to see this patient first? The majority would raise their hand. Okay, you guys, 3 of you chose to see somebody else. Let's talk through that. And again, it wasn't, did they set the IV pump correctly? It wasn't about the skills. It was that thinking that we honed in on. And the way they openly shared was phenomenal. And it really led the debriefing of how things unfolded. And again, always tying to real world. In a matter of a few months or a few weeks, you guys are out there, you're going to be doing these things. And so it was wonderful to see. It was surprising in a lot of ways of things we didn't anticipate, like them being so open and sharing their information of how they proceeded and choices they made. But it really enhanced the debriefing side. And yeah, we are excited to move forward with this as we continue integrating it into the program. And now with so much of the technology side advancing and changing, it's only going to get better and better. And the fact that you can take this on the road per se, rural communities, etc., where you don't need the big fancy sim center, it's a game changer. It's wonderful. So.
Yeah, and I wanted to say something too, to Anne's point of things are moving rapidly, the technology advances, things are changing. At IMSH, we saw so many different things, and even with OMS, so many changes, new features being added, the voice activation, the hand controls, all of that. So remember, we started doing these multi-patients in 2022. Okay, it's now 2026. So when we did, with these scenarios, these were originally designed with the drop-down menu. Okay, so you click. You want to assess, here are your options, you click one. Or you want to do this intervention, you click one. You're doing SBAR communication. Here's your situation. You have 4 choices, you click one. I want everyone to hear me well. That is a great way to learn. And I've heard a lot of people say, oh, well, we don't want to use those drop-down menus. We'd rather have students talk. Sure. There's a lot of value of having students just talk, ask, hearing that patient respond. But I want to say, we did this with over 1,000 students and probably close to 2,000 by this point, where we have had incredible outcomes using those drop-down menus. And I will say, I was a cardiac ICU nurse, and I did some of these scenarios, and reading the options was not as easy as you think, like, oh, there's the obvious answer, pick that one. So I just want to say that whatever type you are using, whatever that platform looks like, whichever version of any scenario you're using, don't underestimate that, we don't have to have the latest and greatest feature of it. We had great learning with these drop-down menus. I do look forward to some of the voice activation scenarios. I have not had time to move into these yet. I know that communication has always been a big thing, but now with de-escalating angry family members or upset patients, I think that that's something that our students need more equipping, more practice with. And I think this is a great way to do that, because I would never put a student with a standardized patient who is angry and shouting at them. I know that that can be done. It is done. I have a hard time ethically doing that. I'm not saying I love doing that in VR, but it is a reality of healthcare today. It is a reality of nursing that we need to prepare our students, because they will encounter situations like that. And I think that VR is a great way to be able to do that. So I also want to say, Anne kind of addressed how we had a lot of lessons learned. It sounds easy when you look at, oh, here's how we integrated it. We just plopped it into courses. I want to say, don't underestimate the power of a good orientation for your first-time users to the hardware and to the software. Those are two very separate things. What I have been doing, and I will say I've done this with students, I've done this with the University of Minnesota Board of Regents, and it works really well. I use some of the meta apps. So there's one called North Star, where you are a pirate on a sinking ship. I know it sounds goofy, but you have to swing the rope to ring the bell. You have to roll barrels. So you're doing all of the actions you need to know how to do using the hand controls, talking, in your headset, or seeing what you need to see. And it's a very fun way to immerse people. So number one, they're getting what it means to be immersed. And number two, they're learning how to use just the hardware itself. I think there's another one called First Steps that's really fun, that we've had a good response to that as well. So after we do that type of an orientation, then we move into OMS and we do an orientation to OMS. OMS has a lot of different videos that you can give to students, different materials to onboard them, and those are always improving. So we're seeing great success with that. There's an orientation scenario that you can go through where the student can just become familiar with that virtual environment. What does this hospital room look like, right? They know hospital rooms, but they need to see, what does this one look like? That aligns with the standards of best practice, right? We want to do a full orientation. So we have found when you do those, and you do those well, students then are ready to move into their first learning experience. I think one of the things that was challenging for our project was that we had to kind of put all of that orientation together when they did their first scenario. And so that probably impacted some of our outcomes. But now moving forward, I build in a lot of time to make sure that our students have ample time to learn how to use the headset and then learn how to use OMS. Yep. So I think I got off slides here. So going back to our slides, I think we've talked about this. Yes, immersive VR can completely augment simulation education for many reasons, one of them being cost. We are actually converting a lot of our formerly traditional simulations with mannequins and SPs. We're converting a lot of those to VR and having good success with that. I do think VR is a very scalable, more cost-effective simulation method. Yes, we pay for hardware. Yes, we pay for software, but we're not paying for consumable supplies. We're not paying to train SPs and employ them to do X number of scenarios with students every single semester. So a lot of those recurring expenses go away, which does make this more cost effective for some programs. And then, as I've said, the data analytics, I think we have so much potential, especially when you combine AI with analyzing and giving us meaning. Like, what does this data show us? How does this inform me for this cohort of students? How do we improve their learning experience so that in true competency-based education format, we can focus on those things that they're struggling with to really empower them to grow and to learn. And then I think, Don Marie, I think you said you're going to share these slides. So there's a couple of QR codes here to a couple of articles. The first one, Breaking Boundaries, was actually one of the most cited articles of the Journal of Nursing Regulation. Both of these give a pretty good explanation of what we've gone through here as far as how did we integrate them into our courses. Both of them include some of the different measures that we use with our outcomes, also some of the usability measures that we want to know, like how are students responding to the technology itself. I'll leave this slide up in case you want to scan those codes, but then we can open up for some questions now.
So I have a nice queue of questions for you all. First question is, can you talk about some of the tools you are using to measure sense of presence?
Yeah, so sense of presence itself there's a sense of presence questionnaire. That is the one we are using. It has been used widely across all research using virtual reality, not just specific to nursing or healthcare. So if you just Google the sense of presence questionnaire, you will find it. The other usability things that we've used, not specific to presence, but it really does play into it, is the SUS, the usability survey, and then the NASA TLX looking at cognitive workload.
Next question, did students receive compensation for their participation, or was it part of their coursework?
Part of their coursework.
So we did offer for the first year of the study, it was part of their coursework. What we offered them compensation for was to allow us to use their de-identified data in the data set. But all students were required to do it because it was part of their coursework.
Okay. How did you work with students who refused to go into the headset and only work on screen?
So that is a really good question. I don't know that I've never had a student refuse to go into the headset. I have had a few come to me and say, I suffer from migraines, I get a lot of dizziness, I just don't want to do it. I will never force anyone to put on a headset. I myself suffer from migraines and a lot of motion sickness, and so I would never put someone in that situation. But what I do, and I would encourage you to do, is a really, really deep education and orientation. In nursing scenarios, we are in total control of that environment. Things are not flying past us. We're not going on roller coasters. We are stationary, and we can move and we control everything that is happening in that scenario. So that's one of the main causes of motion sickness. I also think that as technology advances, we're seeing far less cyber sickness. I think the other thing is it's all in how you frame it. If you come right out to your new students and you say, hey, we're going to do something today, it might cause you to get cyber sickness though. So raise your hand if you don't want to get sick. Don't do it that way. Just say, this is what we're doing. Our students are pretty good at advocating for what they need. So they come to us and they tell us if they are just not able to tolerate a headset. I think the next thing is do a really good orientation so that they know how to use that headset. There's a lot of tips that you can use to help minimize that motion sickness. You know, whether you're standing or sitting, I recommend if students are hesitant, have them sit on the edge of their seat with their feet apart, firmly planted on the ground so that you are really in control. Have them look down their nose at the floor every now and then to really recenter yourself, to tell your brain, yeah, I'm really sitting in this chair and my feet are on this floor. Make sure the room is not too hot. You know, there's a lot of things that you can do to help minimize that, but I really encourage students to do that. Now, I will say, I have seen situations where none of that happens, and one student says, I have a headache, or I'm sick, I can't do this, I want to use my laptop. Pretty soon, your entire class will be on their laptops. And I am, again, hear me well, I am not advocating for making students do something that makes them sick or uncomfortable, but what I am advocating for is that you frame it really well, you give some good education. What I ask students to do now, if they can't tolerate a headset, I ask them to do the scenario on their laptop and then just come and join the class for the debriefing. It's very distracting for someone to be on a laptop and you have people in headsets and they're all in that same room. It's distracting for everybody. So the laptop users will do it before they come and they just join at the debriefing.
During the 2.5 years of the study, we had a total in 2.5 years of 4 students, that's it, that used their laptop, that couldn't tolerate it. And again, it was migraine related. Once the study was over, even though we're still doing this in the classes, it was exactly what Dr. Bradley said. There was one person that just right from the gate said they needed to use a laptop. All of a sudden, we had a grad student down there helping. I come back down, there's like 7 people on their laptop. I thought, now we just did this for 2.5 years with 0 issues. And so again, it's how you approach it. Exactly what Dr. Bradley said. I talked significant time spent on how to make sure that headset is positioned comfortably. And so vision is not blurred and you don't feel pressure. And here, let me help you with that. And students typically are fine and you move right along. So taking the time to get them acclimated early on definitely makes a difference.
And I will note, as has been mentioned several times, this study initially started several years ago. And with that technology change, we're looking at headsets that have a much quicker refresher rate than those initial headsets that we used. And oftentimes that contributes to cyber sickness. So the newer headsets are just worlds apart better. So I would note that as well. Another question, just to clarify, did you mention each scenario took 2 hours? So all 5 took about 10 hours to complete?
So the scenario itself did not take 2 hours. What the 2-hour session was very similar to how we schedule our simulation, traditional simulation sessions. So that means at the start of the 2-hour session, that's when students come in, we do our pre-brief, they get their headset, they do the scenario. We allow about 1 hour for all of that. And then we allow about 1 hour for the debriefing and cleanup and all of that type of stuff.
Yes.
And final question, have you tried any of the multi-user versus one patient scenarios? And if so, how did those turn out?
I personally have not. For the purpose of this project, this was really about independence, practicing to the fullest scope of your license as an independent nurse. If you're looking at maybe your sophomore students or your junior students where you want to put them together, or you're looking at interprofessional scenarios where you have multi-users, I know people are having great success with that. So I think it's, what is your objective? Let your objective drive what scenarios you use and what format you use.
Okay. Well, that concludes our presentation for today. Special thanks to Dr. Bradley and Dr. Loomis and all of their colleagues who were not able to join us today. This work is impactful and it's important to share. I encourage you to reach out to them if you have any additional questions. If you'd like to learn more about OMS, please scan the QR code on your screen to speak with one of our experts here. Again, I hope you all have a wonderful week. The recording will be available shortly, both on our website as well as we will send it in an email. Thank you.
Thank you so much.
Thank you.